Good day, everyone. I'm Dr. Jill Soon, and today we'll be talking about dyslipidemia or abnormal lipid levels in the blood. We will be discussing about the basics on lipids and the management guidelines for dyslipidemia. The major clinical compounds classified as lipids are triglycerides, phospholipids, and cholesterol. Now, what are triglycerides? Triglycerides are esters consisting of one glycerol and three fatty acids. Now, we also need to understand what is the difference between a saturated fat and unsaturated fats. So, saturated fats are those with chemical formulas which do not have double bonds between two carbon molecules. While on the other hand, unsaturated fat has one or more double bonds between the carbons, and it has a lower melting point and as such is often liquid at room temperature. How about phospholipids? Phospholipids are lipids whose molecules has a hydrophilic head with a phosphate group and two hydrophobic tails derived from fatty acids. These are joined by an alcohol residue, usually a glycerol molecule. Phospholipids often occur with other molecules such as proteins, glycolipids, steroids, and forms a bilayer such as the one that's present in the cell membrane. Now, the third lipid molecule is cholesterol. Cholesterol is the principal sterol of all higher animals. It is distributed in body tissues, especially the brain and spinal cord, and in animal fats and oils. Now, in our peripheral cholesterol, majority of this cholesterol is ingested or synthesized by the hepatocytes and transported in the blood to peripheral cells. The levels of cholesterol in peripheral tissues is dictated by the balance between uptake and export of these compounds. Cholesterol present in the brain is mainly produced and distributed by the astrocytes. De novo synthesis, both in astrocytes and hepatocytes, occur by a complex 37-step process which is shown in this slide. So this usually begins with the mevalonate or the HMG-CoA reductase pathway, which is the target of statin drugs, which encompasses the first 18 steps of this pathway. This is followed by 19 additional steps to convert the resulting lanosterol into cholesterol. Whole body cholesterol homeostasis is achieved when input from diet and synthesis is matched by output through excretion in the bile, both as bile acids and biliary cholesterol. Now, this is the structure of a lipoprotein. A lipoprotein is a biochemical assembly whose primary function is to transport hydrophobic lipid, also known as fat, molecules in water, as in the blood, plasma, or other extracellular fluids. They consist of a triglyceride and a cholesterol center, and this is surrounded by a phospholipid outer shell with the hydrophilic portions oriented outward toward the surrounding water and the lipophilic portions oriented inward toward the lipid center. A special kind of protein called apolipoprotein is embedded in the outer shell of the complex lipoprotein molecule. It gives the molecule a stabilizing effect and it gives its functional identity, determining its role in lipid metabolism. When we do lipid profile test, we usually determine the different levels of the types of lipoprotein. So we have here an illustration showing the proportion of the cholesterol, triglyceride, phospholipid, as well as apolipoprotein component in each of the different molecules present in our blood. Now, take note that the chylomicron is made primarily of triglycerides. That is why it is a very big molecule because of its large triglyceride content. On the other hand, the VLDL, there is an increasing amount of phospholipid, apolipoprotein, as well as cholesterol with lesser amounts of triglycerides compared to chylomicron. And as we progress further, from the IDL to the LDL, there is a progressively decreasing amount of triglycerides. And looking at the apolipoprotein component as well as the cholesterol component, it tends to increase as we progress from the VLDL to the LDL molecule. Now, looking at the HDL, or which is called the good cholesterol, it has a very minimal amount of triglyceride, and a majority of the molecule is made up of apolipoprotein as well as phospholipid. The next slide shows cholesterol transport from the gut to the system. So from the dietary fat that we take in, the chylomicrons carry triglyceride from the small intestine to the body cells. Now these chylomicrons are acted upon by lipoprotein lipase to become fatty acids and glycerol. Now, this lipoprotein lipase is an extracellular enzyme on the vascular endothelial surface anchored to the capillary walls. This enzyme is predominantly in the adipose tissue, the muscle, and the heart tissue, but not in the liver, as the liver has its own hepatic lipase. The lipoprotein lipase is an enzyme that degrades circulating triglycerides in the bloodstream. It functions to convert triglycerides to fatty acids and glycerol. So, after being subjected to the action of lipoprotein lipase, the chylomicron remnant travels to the liver for disassembly. And in the liver, the VLDL is produced by bringing more triglycerides to the body cells. And after that, the VLDL becomes an intermediately dense lipoprotein, and then cholesterol-rich LDL is produced as triglycerides is removed from that molecule. And the next phase is that the LDL that is produced delivers the cholesterol, its cholesterol contents to the body cells. And lastly, the HDL, it picks up the excess cholesterol and delivers it to the liver for use or for disposal. The next slide shows us the different kinds of apolipoproteins. Now, the apolipoproteins provide structural stability to the lipoprotein. It serves as ligands for interaction of the lipoprotein receptors that help determine the disposition of individual particles. It also acts as cofactors for enzymes involved in plasma lipid and lipoprotein metabolism. Now, looking at the different classes of lipids, the chylomicrons, the major apolipoproteins in chylomicrons are apolipoprotein A, B48, C, and E. Now, apoprotein B10 functions mainly for secretion of VLDL from the liver, and it is also a structural protein of VLDL, IDL, and HDL, and it is a ligand for LDL receptor. Apoprotein B48, its function is for the secretion of chylomicrons from the intestine, while apoprotein C functions for the activation of the LCAT, while apoprotein E is a ligand for binding of IDL and remnants to the LDL receptor. Now, looking at the VLDL, its main apolipoprotein is B100, C, and E as mentioned earlier. LDL has a major apolipoprotein made up of B100, while the HDL has apoprotein C, A, D, and E. Now, the next slide shows us the function of the lecithin cholesterol acyltransferase, or LCAT. This is a lipoprotein-associated enzyme and is a key player in the reverse cholesterol transport pathway, which promotes the transfer of excess cellular cholesterol from peripheral tissues to the liver for excretion. With normal LCAT activity, the HDL particles acquire unesterified cholesterol from the peripheral cells, and the LCAT esterifies cholesterol in HDL particles, which we call the alpha activity. This promotes the conversion of the spherical mature particles that can then be further remodeled by circulating enzymes such as CETP and facilitates the transfer of triglyceride from ApoB containing lipoproteins to HDL in exchange for cholesterol esters. Mature HDL can transport cholesterol to the liver for excretion. That is the reason why HDL is a good cholesterol, because it tends to transport cholesterol out of the uh, arterial wall into the liver for excretion. So in addition, LCAT, it esterifies cholesterol to a lesser extent in ApoB containing lipoproteins, or the which we call beta activity. LDL particles can be cleared by the liver through LDLR mediated pathway or be taken up by peripheral cells. Accumulation of LDL in the arterial wall contributes to atherogenesis. This next slide shows us that in subjects who have mutations wherein the alpha and beta activity is lost, nascent HDL particles may preserve their ability to promote unesterified cholesterol efflux from the peripheral cells, but they fail to convert the mature HDL, which are rapidly cleared by the body. Cholesterol ester poor LDL particles are cleared faster by the liver and may display a less atherogenic potential. So as you can see in panel B, there are less cholesterol in the arterial wall and therefore less atherogenesis. On the panel C, we see patients who have mutations of the alpha activity. Loss of alpha activity will have a fate similar to the patients with mutations in panel B. However, if the beta activity is preserved, this leads to the formation of cholesterol ester-rich LDL particles with atherogenic potential, which is comparable to the control subjects. Apoprotein B, which is present in the LDL, it determines its atherogenicity. If you look at panel C, if there is the formation of cholesterol ester rich LDL, it tends to promote accumulation of cholesterol in the blood vessel. Whereas if you have decreased activity in the HDL efflux of cholesterol, there will be a net accumulation of lipids in the blood vessel. Now, after discussing the basics of lipid metabolism, let us now go to a discussion about the clinical practice guidelines in the management of dyslipidemia. This is the Philippines' own lipid management guidelines, which is published in 2020. So this is the executive summary, which was published in the Journal of the ASEAN Federation of Endocrine Societies in the year 2020. So let's start our discussion on the guideline. So dyslipidemia is cardiovascular risk factor that is increasing in prevalence in our country. Thus, we need to treat and manage elevated cholesterol levels both by pharmacologic and non-pharmacologic means, because it is important to so as to influence the outcome of our patients. So this clinical guideline was done in collaboration with the different societies in the Philippines, the Philippine Heart Association of Cardiologists, and also the Philippine Lipid and Atherosclerosis Society, or the PLAS, the Philippine Society of Endocrinology, Diabetes and Metabolism, the Philippine Society of Nephrology, the Philippine Neurological Association, and the Philippine Pediatric Society. The objective of this clinical practice guideline is to provide clinicians or physicians with a review of the latest available researches in the field of dyslipidemia to produce recommendations adaptable locally in the Philippines. And this also aims to provide evidence-based recommendations to effectively manage individuals with dyslipidemia. And lastly, to identify effective and feasible treatment regimens, both non-pharmacologic and pharmacologic, in dyslipidemia treatment. Now, when we published clinical practice guidelines, there is a rating and ranking of clinical outcomes using the grades of recommendation, assessment, development, and evaluation, or grade 2 categories with a scale of 1 to 9. So the important clinical outcomes that were considered in this guideline is total mortality, cardiovascular death, fatal and non-fatal MI, stroke or cerebrovascular disease, which has a grade category of critical. Major adverse CV events and coronary revascularization is an important clinical outcome as well. Now, in the literature search, PubMed, Scopus, Medline, and etc., as well as Cochrane were used to look for RCTs, meta-analysis, or systematic review. It included studies wherein the individuals that were studied had the presence or the absence of established coronary heart disease, CVD, and with or without risk factors for coronary heart disease, CVD, and diagnosed with elevated blood cholesterol. So these are the important clinical questions that are important in dyslipidemia management. It pertains to non-pharmacologic management, primary prevention in both non-diabetic individuals and those with diabetes already. It also has clinical questions pertaining to the familial hypercholesterolemia, clinical questions on secondary prevention, adverse events of statins, and the use of other lipid parameters as measurement of risk for cardiovascular disease. Clinical question number 1 pertains to lifestyle modification, and it asks, among individuals with dyslipidemia, regardless of their present condition or risk profile, should lifestyle modification in the form of reduced fat diet, smoking cessation, regular physical activity be advised to reduce overall cardiovascular risk? The statement in the clinical guidelines recommend that lifestyle change play a major role in the management of dyslipidemia. A low-fat, low-cholesterol diet is recommended. We recommend that the Filipino individual with dyslipidemia utilize the Pinggang Pinoy that is advocated by the Food, Nutrition, and Research Institute of the Department of Health. It is a serving plate where half of the portion is green and leafy vegetables, 1/4 serving of meat, and the rest are fiber-rich carbohydrates. The guideline also strongly recommend that patients should stop smoking and that the use of vaping or e-cigarettes is also not recommended for individuals with dyslipidemia. Exercising at least 150 minutes per week at moderate to high intensity is recommended. With regards to the use of polyunsaturated fatty acid N3 series, although there is no direct hypercholesterolemic effect, habitual fish consumption is associated with reduced cardiovascular risk, mostly independent of any effect on plasma lipids. Dietary fiber in the form of soluble type found in legumes, fruit, vegetables, and wholemeal cereals, there it is noted to have a direct hypercholesterolemic effect. As for body weight reduction, it highly influences the total cholesterol and LDL cholesterol. The magnitude of the effect is rather small. However, among obese individuals, there is a note of reduction of 0.2 millimoles per liter or 8 milligrams per deciliter per 10 kilogram of weight loss. Now, what are the lifestyle interventions that can have a impact on the lipid levels of total cholesterol and LDL-C cholesterol? The ones that have general agreement of its effects on total cholesterol and LDL are reduction of dietary saturated fat, reduction of the dietary trans fat, and also the utilization of foods rich in phytosterols. As for the other interventions in this slide, the effect on lipid levels is either less pronounced or that its efficacy is less well established. As for lifestyle intervention that can help reduce triglyceride level, what is generally proven effective for lipid lowering of triglyceride is the reduction of excessive body weight, reduction of alcohol intake, reduction in the intake of mono and disaccharides. That is the reason why we need to advise our patients with very high triglycerides to lose weight, not to consume excessive alcohol, and also to reduce their rice intake or intake of food that are very rich in carbohydrates. Now, for the interventions that can help increase HDL-C levels, these are the reduction of dietary trans fat as well as increase in physical activity. For the other interventions, their effect on the lipid profile is either less pronounced or less well established. Now, let's go to clinical question number 2 on primary prevention. This primary prevention pertains to individuals who have no prior atherosclerotic cardiovascular disease. And the question is, among non-diabetic individuals without ASCVD but with multiple risk factors, should statin therapy be given? Now, statin therapy will be discussed later on in the subsequent slide as to how it will affect our lipid levels. Now, the next slide shows us what are the risk factors that are generally considered when risk stratifying our patients. So, these are male sex, postmenopausal women, smoking, hypertension, BMI more than 25 kilograms per meter squared, a family history of premature CHD, proteinuria, as well as left ventricular hypertrophy. Now, when we talk of atherosclerotic cardiovascular disease, it pertains to myocardial infarction or other acute coronary syndrome, coronary or other revascularization procedure, transient ischemic attack, ischemic stroke, atherosclerotic peripheral arterial disease, or the presence of an ankle brachial index of less than 0.9, as well as other documented atherosclerotic diseases such as coronary atherosclerosis, renal atherosclerosis, aortic aneurysm secondary to atherosclerosis, and the presence of carotid plaque more than 50% obstruction. Now, what is a statement with regards to primary prevention? For individuals without diabetes aged more than 55 years old, with LDL-C more than or equal to 130 milligrams per deciliter and the presence of 2 or more risk factors, even without the presence of atherosclerotic cardiovascular disease, statins are recommended for the prevention of cardiovascular events. The next slide shows the mechanism of action of statins. So, statins are HMG-CoA reductase inhibitor. So, conversion of 3-hydroxy-3-methylglutaryl-CoA or in short HMG-CoA to mevalonate by HMG-CoA reductase in the hepatocytes is the first and rate-limiting step in cholesterol biosynthesis. Statins competitively inhibit HMG-CoA reductase enzyme. Statins bind to the active site of the enzyme and induce a conformational change in its structure, thus reducing its activity. Also, the binding affinity of statins for HMG-CoA is 10,000 times higher than the substrate of HMG-CoA, thus preventing the action of the enzyme and reducing the intracellular synthesis of cholesterol. Statins have a significant impact on lowering cholesterol since most of the circulating plasma cholesterol comes from the internal synthesis in hepatocytes rather than the diet. The reduced intracellular concentration of cholesterol in hepatocytes secondary to statin use activate the proteases that cleave membrane-bound sterol regulatory element binding protein or SREBP, which further migrate to the nucleus and bind to sterol response elements. This binding results in increased transcription of the LDL receptor, which translocates to the liver cell membrane. The LDL and VLDL particles in the plasma bind to the LDL receptors and endocytose in the hepatocytes, where their cholesterol component gets processed into bile salts, which are then excreted and recycled. This process increases the catabolism of LDL and VLDL cholesterol and results in further reduction of plasma cholesterol concentrations. This slide shows what is the role of LDL receptor mentioned earlier. LDL receptors carry LDL particles into the hepatocytes via clathrin-coated vesicles which fuse with endosomes, allowing recycling of LDL receptors to the cell membrane up to 150 times. The binding of LDL to the LDL receptors allows the LDL particles found in the plasma to be degraded in the hepatocytes, thus reducing the LDL levels of the patient. Thus, the use of statin has the following protective effects or pleiotropic effects on top of its lipid-lowering effects. It helps in plaque stabilization, it reduces inflammation, and it also improves endothelial function and decreases thrombogenicity. Now, what is the impact of reducing LDL levels in our body? So, for every 1 millimole per liter or 40 milligrams per deciliter LDL reduction, there is a 10% reduction in all-cause mortality, a 20% reduction in CAD death, and also a 23% reduction in the risk of coronary events, and a 17% reduction in the risk of strokes. These benefits are noted to be significant within the first year but were greater in subsequent years. There is no increased risk of any specific non-cardiovascular cause of death, including cancer, with the use of statin therapy. As for the elderly population, the European Society of Cardiology guideline states that primary prevention measures in the elderly should not differ from those undertaken in younger subjects. This is because almost 25% of men and 42% women older than 65 years old have total cholesterol greater than 6 millimole per liter or 240 milligrams per deciliter. Elderly individuals are a high-risk group who could benefit significantly from lipid-lowering therapy to reduce cardiovascular morbidity and mortality. There is evidence for treatment above age 80 to 85%. However, the evidence is very limited, and that clinical judgment should guide the decision for the very old population. A study, the PROSPER or the prospective study of pravastatin in the elderly at risk, included subjects at 70 and 82 years old with a history of risk factors for cardiovascular disease, following up these patients for 3 years while on treatment with pravastatin. It was noted that there was a 34% reduction in LDL-C levels and a 13% reduction in triglyceride levels. There is also a 15% decreased risk in coronary death, non-fatal MI, and stroke. And however, it could not reduce total mortality or improve cognitive dysfunction. Another question with regards to primary prevention is about individuals with diabetes mellitus, and it asks, among individuals with diabetes without atherosclerotic cardiovascular disease, should statins be recommended? So this question asks about whether if a person is diabetic, even if there is no acute MI, no stroke, or no other atherosclerotic arterial diseases, should we give them statins? So, the statement in the guidelines says that for individuals with diabetes without evidence of ASCVD, statins are recommended for primary prevention of cardiovascular events because statins are noted to decrease by 20% the 5-year major cardiovascular event incidence for every 1 millimole per liter reduction in LDL-C, regardless of the initial LDL cholesterol level or other baseline characteristic. The statin dose should be optimized to reach the LDL goal. So for most persons with diabetes, for primary prevention, the LDL goal should be less than 100 mg per deciliter. Among diabetic patients with more than one risk factor, the LDL cholesterol goal should be less than 70 milligrams per deciliter. However, for secondary prevention, meaning those patients who had an event prior, in these individuals who are diabetic and are extremely high risk of having recurrent cardiovascular events due to previous occurrence of major cardiovascular events such as MI, unstable angina, or stroke, the LDL cholesterol target should be much lower at less than 55 milligrams per deciliter. Now, the third clinical question pertains to patients with familial hypercholesterolemia. So, among high-risk individuals identified to have familial hypercholesterolemia, should statin therapy be started? So, what is familial hypercholesterolemia? It is a predominantly inherited gene disorder resulting from gene mutations in the LDL receptor pathway that causes markedly elevated LDL cholesterol from birth. So, early diagnosis and treatment are vital in the prevention of cardiovascular events in this high-risk population. Diagnosis can be made through the Dutch Lipid Network criteria, which takes into consideration the patient's family history of first-degree relatives with known premature coronary vascular disease or first-degree relative with known LDL-C above the 95th percentile, or a first-degree relative with tendinocytoma and/or Cus cornealis, or children less than 18 years with LDL-C level above the 95th percentile. Another criteria is the clinical history with regards to the presence of premature coronary artery disease and premature cerebral or peripheral vascular disease. When we say premature, these are events which occur in less than 55 years old male or less than 60-year-old females. Physical examination are also considered, wherein those who have tendinocytomata and arcus cornealis prior to the age of 45 years old are assigned specific points. Cholesterol levels are also graded based on its severity and its corresponding points. DNA analysis can also be one of the criteria, wherein a functional mutation in the LDR receptor, ApoB or PCSK9 gene is noted. Now, the diagnosis of FH will depend on the number of points obtained from this Dutch Lipid Network criteria, wherein definite familial FH corresponds to more than 8 points, probable corresponds to 6 to 8 points, possible FH is 3 to 5 points, and those who have less than 3 points are unlikely to have familial hypercholesterolemia. The recommendations in this guideline is that for individuals identified to have familial hypercholesterolemia, statin therapy is strongly recommended for the prevention of cardiovascular events. The recommended statin therapy is high dose of statin with a target of less than 70 milligrams per deciliter in FH patients without target organ damage, or less than 55 milligrams per deciliter for FH individuals with target organ damage. Now, how do you define high-intensity statin therapy? Take note in the red box is that atorvastatin and rosuvastatin are the only drug regimen included in the high-intensity statin therapy, wherein atorvastatin is given at a dose of 40 to 80 milligrams, while rosuvastatin is given at 20 to 40 milligrams. Now, what does high-intensity statin means? It means that if you give this kind and dose of statin, there will be a corresponding more than 50% reduction in LDL cholesterol. Whereas for moderate intensity statin therapy, there is a 30 to 50% LDL-C reduction using the following drugs and its corresponding doses. Whereas low intensity statin therapy results to less than 30% LDL reduction using the following drugs and its corresponding doses. Now, the next clinical question pertains to dyslipidemia in the pediatric population. Among pediatric population at risk for premature cardiovascular disease, should screening with fasting lipid profile be recommended? The screening for dyslipidemia in childhood is made on the basis of early identification and control of pediatric dyslipidemia that will reduce the risk and severity of cardiovascular disease in adulthood. There has been no solid evidence so far with regards to the screening recommendation for dyslipidemia among the pediatric age group. In this clinical practice guideline, the screening guidelines that have been suggested are the following: selective screening for those at risk, and universal screening to identify those with risk factors for familial hypercholesterolemia at 9 to 11 years old and 17 to 21 years old. We have here in this slide the traditional risk factors such as dyslipidemia, obesity, type 1 and 2 diabetes, hypertension, family history of premature CVD, and smoke exposure as mentioned in the previous slide. The other risk factors that are considered are FH, CKD, Kawasaki disease, childhood cancer, transplant vasculopathy, the presence of certain congenital heart disease such as coarctation of the aorta and aortic stenosis, cardiomyopathy, chronic inflammatory disorders, HIV infection, and adolescent depressive and bipolar disorders. The statement with regards to dyslipidemia in the pediatric population states that among pediatric population less than or equal to 19 years old at risk for developing atherosclerosis with premature cardiovascular disease, screening with fasting lipid profile is recommended. The screening guidelines that have been suggested are the following: selective screening of those at risk, and as mentioned earlier, universal screening for those with risk factors at age 9 to 11 and 17 to 21. According to the European Society of Cardiology Dyslipidemia Guideline of 2019, diet is the mainstay of treatment for dyslipidemia in childhood. Only FH should be considered to be given lipid-lowering drug treatment, and focus should be on diet and treatment of underlying metabolic disorders. Clinical question number 5 deals with individuals with chronic kidney disease. And it asks whether among individuals with chronic kidney disease who are not on dialysis, should statins be given to reduce cardiovascular disease. Dyslipidemia is common but not universal in CKD. Kidney dysfunction leads to a profound dysregulation of lipoprotein metabolism, resulting in multiple lipoprotein abnormalities. The recommendation in this local guideline is to give statin for individuals with CKD not on dialysis. For individuals who are on renal replacement therapy and post-transplant, this local guideline recommends referring patients to nephrologists for lipid management. It is noted that among CKD patients, there is a 19% decrease in the risk for all-cause mortality based on the pravastatin pooling project on statin therapy. There is also an 11% absolute risk reduction in the mild CKD subgroup based on the heart protection study. For patients on CKD on dialysis, results from patients with advanced CKD stage 4 and 5 and on dialysis are less clear. The 4D study, which included 1,200 patients with diabetes on hemodialysis, it showed that atorvastatin had no positive effect on the primary composite endpoints of CVD. The Aurora study, on the other hand, which included 2,776 patients on hemodialysis, it showed that rosuvastatin lowered LDL-C as expected. However, there was no significant effect on the composite cardiovascular disease endpoint. These negative results question the benefit of statins in these very high-risk patients with poor outcomes. Now, the sixth clinical question on secondary prevention pertains to individuals with acute coronary syndrome. Among individuals with acute coronary syndrome or ACS, should statins be given? The slide shows the development of an atherosclerotic plaque which starts with the retention of LDL particles in the plasma and its insertion into the vascular endothelium. These oxidized LDL and the recruitment of monocytes by chemoattractant factors lead to the uptake of LDL by the macrophages, which later transforms into foam cells. The foam cells interact with the fibrous connective tissues and the smooth muscle cells of the endothelium to produce an atherosclerotic plaque. Acute coronary syndrome happens when there is rupture of the surface of the vulnerable plaque, which is defined by a thick lipid core which is necrotic and is lined by a thin fibrous cap which is prone to rupture under the influence of the mechanical stress from turbulent flow across the narrowed lumen of the vessel. Timing of therapy is critical among patients with acute coronary syndrome. Early intervention is advocated to optimize recovery and minimize complication. Hence, the adage that time is muscle and is based on the principle of the necessity of immediate action during the golden period in which myocardial ischemic damage is still potentially reversible or myocyte necrosis can still be contained and much of the myocardium is in the ischemic penumbra which can still be salvaged. Evidence on the appropriate statin therapy for secondary prevention in individuals with ASCVD were obtained from 4 clinical trials that compared varying statin regimens. High-intensity statins, which reduce LDL by more than 50%, compared to those lower-intensity statins with reduced LDL by less than 30%. The guidelines, especially of the European Society of Cardiology, recommend that high-dose statin therapy be initiated within the first 1 to 4 days of hospitalization for the index acute coronary syndrome. If LDL basal values are known, the dose should aim at reaching the target LDL of 1.8 millimoles per liter or less than 70 milligrams per deciliter. Now, the next clinical question pertains to non-statin therapy or the use of ezetimibe. Among individuals with ASCVD, should ezetimibe be given on top of statin therapy? Ezetimibe is an important adjunct medication in lowering LDL-C in the body. This guideline recommends that ezetimibe should be given to patients with documented ACS on maximally tolerated statin therapy, not at goal LDL-C level. Based on the SHARP trial on CKD patients and the C study on aortic stenosis, it is noted that ezetimibe monotherapy results to a reduction of LDL-C by 15 to 20%. Combining ezetimibe with statin therapy, there is an incremental decrease in LDL-C of 15 to 20%, whereas combination of simvastatin plus ezetimibe results in 17% reduction in cardiovascular events. Ezetimibe is the first lipid-lowering drug that inhibits intestinal uptake of dietary and biliary cholesterol without affecting the absorption of fat-soluble nutrients. Ezetimibe inhibits the Niemann-Pick C1-like protein or the NPCI-L1, which is responsible for cholesterol absorption in the small intestine. This prevents cholesterol-containing micelles from entering the enterocytes. By inhibiting cholesterol absorption at the level of the brush border of the intestine, ezetimibe reduces the amount of lipoprotein cholesterol circulated to the liver. Also, by reducing enterocyte cholesterol absorption, chylomicron formation and secretion, as well as the backflux of cholesterol from the bile, ezetimibe depletes hepatic pools of cholesterol and increases the expression of LDL receptor on the surface of hepatocytes. And as we all know, if the more LDL receptor that is expressed in the surface of the hepatocyte, the greater degradation of LDL cholesterol happens through the endosome, and thus reducing the level of LDL cholesterol in the serum. The next clinical question, also on the non-statin therapy, pertains to the use of fibrates. Among individuals with ASCVD, should fibrates be given on top of statin therapy once LDL-C goal is achieved? The lipid-lowering mechanisms of fenofibrate is such that fibrates are agonists of the peroxisome proliferator activated receptor alpha, or PPAR alpha, acting via transcription factors regulating various steps in lipid and lipoprotein metabolism. By interacting with PPAR alpha, fibrates recruit different cofactors and regulate gene expression. As a consequence, fibrates have good efficacy in lowering fasting triglyceride levels as well as postprandial triglyceride and triglyceride-rich lipoprotein remnant particles. The HDL-C raising effects of fibrates are modest. So in general, fibrates, which activate the PPAR alpha, results to the following effects: decrease in hepatic lipogenesis and VLDL secretion, increase in fatty acid oxidation in liver and muscles, increase in lipoprotein lipase activity, increased transcription of ApoA1 and A2, increased transfer of phospholipid and cholesterol to HDL, as well as remodeling of LDL particles. The statement in the clinical guideline with regards to the use of non-statin therapy states that among individuals without diabetes not at goal LDL-C, routinely adding fibrates on top of statin therapy is not recommended for primary or secondary prevention of cardiovascular disease. Also, among individuals with diabetes, routinely adding fibrate on top of statin therapy is not recommended for primary and secondary prevention of cardiovascular disease. The reason behind this recommendation is because the overall efficacy of fibrates in CVD outcomes is much less robust than that of statins, meaning there are less clinical trials proving its efficacy compared to that of statins. However, adding fibrates to statins may be considered among men with controlled diabetes, low HDL less than 35 mg per deciliter, and persistently high triglycerides more than 200 mg per deciliter for prevention of cardiovascular disease. It is noted that there is increased cardiovascular risk if fasting triglyceride is 1.7 millimoles per liter or 150 mg per deciliter. The use of drugs to lower triglyceride should only be considered with triglyceride of 2.3 millimoles per liter or more than 200 mg per deciliter. Among patients who cannot lower triglyceride levels by lifestyle measures alone, and if the subject is at high total cardiovascular risk, since fibrates is known to decrease major cardiovascular events by 13%. Triglyceride and cardiovascular disease. Although the role of triglyceride as a risk factor for CVD has been strongly debated, recent data strongly favor the role of triglyceride-rich lipoprotein as a risk factor for cardiovascular disease. Recent large prospective studies reported that non-fasting triglyceride predict CHD risk more strongly than fasting triglyceride. Whether the impact of high triglyceride level on CVD risk is explained by the burden of remnant particles, small dense LDL particles, or associated low HDL remains unsettled. Now let's talk about the impact of very high triglyceride levels. Take note that the risk of pancreatitis is clinically significant if triglyceride level exceeds more than 10 millimoles per liter or more than 880 milligrams per deciliter. 10% of all cases with pancreatitis are due to increased triglyceride levels, and that patients can develop pancreatitis with triglyceride of 5 to 10 millimoles per liter, corresponding to a value of 440 to 880 milligrams per deciliter. When you look at triglyceride level, what is relevant is that big particles such as the chylomicron and VLDL and IDL are composed of mainly triglyceride. These are the molecules that can form cholesterol stones and eventually result to pancreatitis. The more atherogenic molecule is the LDL because it has smaller triglyceride components, and because of its size and density, it is able to insert into the vascular endothelium. Whereas the bigger particles, what we need to be cautious about is its risk of developing pancreatitis. Now, the next clinical question on non-statin therapy pertains to the use of omega-3 fatty acids. N fatty acids, or the eicopentaenoic acid or EPA and the docosahexaenoic acid or the DHA are components of fish oil and the Mediterranean diet and have been used for lowering triglyceride. N3 fatty acids at pharmacological doses of 0.2 grams per day affect serum lipids and lipoproteins, in particular VLDL concentration. The underlying mechanism is poorly understood, although it may be related at least in part to their ability to interact with PPARs and to a decreased secretion of ApoB. The clinical question regarding omega fatty acids is, among individuals with ASCVD, should omega fatty acids be given on top of statin therapy once LDL-C goal is achieved? N3 polyunsaturated fatty acids reduce plasma triglyceride concentration by limiting their synthesis, but also by decreasing their incorporation into very low density lipoproteins, reducing their secretion and improving the clearance of triglyceride by VLDLs. It has been proposed that N3 PUFAs exert their effects through several mechanisms. First is by decreasing hepatic lipogenesis through the suppression of the expression of sterol regulatory element binding protein 1C or SREBP1C. This leads to a decrease in the expression of enzymes responsible for the synthesis of cholesterol, fatty acids, and triglyceride. Second is an increase in the beta oxidation of fatty acid, which consequent reduction in the availability of the substrate necessary for the synthesis of triglyceride and VLDL. And third mechanism is by inhibition of key enzymes involved in hepatic triglyceride synthesis, such as the acid phosphatidic phosphatase or the acylglycerol acyltransferase. And lastly, the increase in the expression of lipoprotein lipase, which is a key component of the biosynthetic pathway of triglyceride-rich lipoproteins, resulting in a greater removal of triglyceride by VLDLs and circulating chylomicrons. The next slide shows the hypothesized mechanism of omega-3 polyunsaturated fatty acids in decreasing cardiovascular disease risk. So aside from its lipid effects, omega-3 has an effect on stabilization of plaque, has anti-inflammatory effects, has membrane stabilizing effects, and also anti-thrombotic effects. The statement on non-statin therapy by the local guideline states that among individuals with ASCVD, omega fatty acids or EPA plus DHA given on top of statin therapy is not recommended. However, among individuals with ASCVD on statin therapy at goal LDL-C but with persistently high triglyceride levels of 150 to 499 milligrams per deciliter, omega fatty acids or pure EPA may be given. Fish oil is known to decrease triglyceride by 30%, however, its effects on other lipoproteins are trivial. The 2020 Clinical Practice Guideline recommends that individuals be divided into 4 patient groups. Individuals with no clinical atherosclerotic cardiovascular disease should target an LDL level of less than 130 milligrams per deciliter. The second subgroup involves diabetic patients who should have an LDL level of less than 100. Those diabetic patients who have more than one risk factor or target organ damage should have an LDL less than 70. But those diabetic individuals with atherosclerotic cardiovascular disease should target an LDL of less than 55. The third subgroup involves individuals with clinical ASCVD wherein the target LDL is less than 55 milligrams per deciliter. Wherein the last subgroup are those with familial hypercholesterolemia, which targets a lesser LDL level of less than 70, even without the presence of ASCVD or major risk factors and target organ damage. However, those with FH and ASCVD or more than one risk factors and target organ damage, the target LDL should be less than 55. As for the HDL cholesterol target, in males it should be more than 40 and in females it should be more than 50 milligrams per deciliter. In general, the target triglyceride level should be less than 150 milligrams per deciliter in all individuals. The next clinical question pertains to the adverse effects associated with the use of statin therapy. Among individuals taking statin therapy, what is the risk of developing adverse effects such as statin-associated muscle symptoms, new-onset diabetes, dementia, cognitive dysfunction, and intracranial hemorrhage? In this clinical guideline, the adverse event outcomes included are hepatotoxicity and rhabdomyolysis, which are considered critical, whereas the important adverse outcomes are hemorrhagic conversion, new-onset diabetes, myopathy, intracranial hemorrhage, elevated liver transaminases. Increase in hepatic transaminases occurs in 0.5 to 2% of patients. It is considered significant if 3 times elevation from the upper limit of normal noted on 2 occasions. The risk factors that increase the likelihood of side effects with statins are advanced age, small body size, female gender, the presence of renal and hepatic dysfunction, perioperative period, hypothyroidism, multisystem disease, and alcohol abuse. The statement on this clinical question is that treatment with statin is associated with a low risk of developing statin-associated muscle symptoms, but the benefits of cardiovascular risk reduction outweigh the risk. The incidence of myopathy is low at 1 over 1,000 versus placebo, which is 1 over 10,000. Myalgia without CK elevation occurs in only 5 to 10% of patients. Tolerable CK elevation is 5 times the upper limit of normal, measured on 2 occasions. This is the algorithm for statin-induced myopathy. On patients who present with myalgia on statin therapy, we should check the creatinine kinase or CK. If the CK is elevated 5 times the upper limit of normal, we should ask whether the patient can tolerate the myalgia. If no, we ask whether there is target organ damage such as kidney damage. If yes, this indicates the presence of rhabdomyolysis and thus we need to discontinue statins. However, in the absence of target organ damage, what we need to do is to closely monitor for 2 weeks of statin therapy and document improvement of symptoms. If with improvement of myalgia, we may resume statin at lower dose or use a different statin. If with no improvement of the statin therapy after 2 weeks, we should look for other causes of myopathy. For those patients who have discontinuation of statin due to rhabdomyolysis, we should have a 6-week statin holiday, and after which we should consider the following: combination therapy with ezetimibe plus low-dose statin, and also a possibility of the use of low-dose rosuvastatin alternate or weekly dosing, or the use of PCSK9 inhibitors. This is the same if the patient has recurrence of symptoms after resumption of statin after 2 weeks of the medication. So these are the statin adverse event statements. Treatment with statin is associated with increased risk of new-onset diabetes mellitus, but the benefit of statin treatment or cardiovascular risk reduction outweigh the risk. Treatment with statin is not associated with development of dementia and cognitive dysfunction, and that treatment with statin is not associated with increased risk of intracerebral hemorrhage. The next clinical question pertains to the use of non-HDL-C as an additional target to reduce cardiovascular risk. Among individuals on statin therapy who have achieved their LDL goal, should non-high-density lipoprotein cholesterol or non-HDL-C be used as additional target to reduce CV events? Non-HDL-C is equivalent to total cholesterol minus the HDL cholesterol. This is the difference between the total cholesterol level and HDL-C, which quantifies all the atherogenic lipoprotein particles. So the target non-HDL value should be 30 mg per deciliter above the target LDL-C. So among individuals on statin therapy who have achieved LDL-C goal, an elevated computed non-HDL-C may be used as an additional therapeutic target to further reduce cardiovascular events. In patients with atherogenic dyslipidemia, such as those with metabolic syndrome, diabetes mellitus, and obesity, non-HDL-C determination is recommended as an additional tool providing a better estimate of risk beyond LDL-C cholesterol. Non-fasting HDL computation has prognostic value in clinical trials as a therapeutic target. Another clinical question regarding the use of apolipoprotein B100 as an additional target to reduce cardiovascular risk is among individuals on statin therapy who have achieved LDL-C goal, should apolipoprotein B100 be used as additional targets to reduce cardiovascular events? Recall in the previous slide that ApoB100 is a major lipoprotein for chylomicrons and very low density lipoproteins as well as low density lipoprotein, which functions for the secretion of VLDL from liver, a structural protein of VLDL, IDL, and HDL, and also as a ligand for LDL receptor. So among individuals on statin therapy who have achieved LDL-C goal, an elevated apolipoprotein B100 may be used as an additional therapeutic target to further reduce cardiovascular events. The next slide shows the general algorithm regarding the treatment of dyslipidemia based on the Philippine practice guidelines. After a thorough history and physical examination, all patients should be advised lifestyle modification in the form of low cholesterol diet, aerobic exercise, smoking cessation, weight loss, and BP reduction. Patients who are diabetic should have statin therapy started. Those with familial hypercholesterolemia should be started on statin. Those with atherosclerotic cardiovascular disease should also be started on statin. Patients who have chronic kidney disease or are not on dialysis should also be started on statin therapy as well. Patients with an LDL level of more than 130 milligrams per deciliter who are more than 45 years old and the presence of 2 or more risk factors should be given statin therapy. And for those who do not have these risk factors but with elevated LDL, they should be reassessed after 6 to 8 weeks. The clinical practice guideline recommendations revolve around the holistic management of dyslipidemia. Lifestyle modification should be recommended to all patients regardless of their CVD risk. Dosing of statin therapy should be based on individual risk factors. We also recommend a lower LDL-C target, particularly for secondary prevention. The simplified algorithm was provided to serve as a quick reference in the management of dyslipidemia for clinicians. This is designed to guide clinicians in managing dyslipidemia for the Filipino patient. However, this should not replace sound clinical judgment by doctors, and the ultimate decision for treatment should involve both the clinician and the patient. This is the working panel that developed the clinical guideline for the management of dyslipidemia in the Philippines. So what about patients who are not at LDL-C goal levels? What should we think about? First is inadequate statin dose or intensity. Second is poor compliance or adherence. Third is intolerance to statin treatment. Or fourth, the hyporesponder due to pharmacogenomic variability. This slide shows the proportion of patients attaining LDL goals in Asia according to the risk category based on the NCEP ATP3 guideline. Take note that among high-risk patients, only 55.4% attain their LDL-C goals, whereas among very high-risk patients who are supposed to reach 70 milligrams per deciliter of LDL, only 34.9% reach the target. This slide shows a proportion of patients attaining LDL-C goals by country. In the Philippines, only 48.6% reach LDL-C goals. Looking at the proportion of patients who are receiving lipid-lowering therapy treatment, in the Philippines, only 33% are being treated, while 19% are not receiving lipid-lowering therapy treatment. We need to take note that there is a residual cardiovascular risk despite statin treatment. This means that this is the percentage of risk that remains even after the patient is given lipid therapy. So, how do we manage low-density lipoprotein cholesterol? So, in general, among patients who have acute coronary syndrome Or for coronary artery disease patients with hypercholesterolemia, the American College of Cardiology and the AHA recommend that statin therapy should be given to target an LDL of less than 70. And if the LDL is not within target or still more than 70 milligrams per deciliter, we should add ezetimibe. And what if the LDL level is still not at goal? We combine statin with ezetimibe. However, if we have LDL level of persistently above 70 milligrams per deciliter, we should add pro-protein convertase subtyrosine kexin type 9 inhibitors or other lipid-lowering therapy. In understanding the significance of PCSK9 inhibitor, we need to understand that LDL receptors aid in the endocytosis of LDL cholesterol bound to its receptors with eventual degradation of the LDL particle. Protein convertase subtyrosine kexin type 9 or PCSK9 binds to LDL receptors, and the complex of LDL receptor with PCSK9 is degraded in the lysosomes. Therefore, increased plasma concentration of PCSK9 results in low levels of LDL receptors at the cell surface and subsequently result to increased levels of circulating LDL cholesterol due to lack of degradation of the LDL cholesterol in the hepatocytes. A PCSK9 inhibitor, which is a monoclonal antibody against PCSK9, inhibits the binding of PCSK9 and LDL receptor, resulting in LDL receptor recycling and increased expression at the cell membrane, which in turn increases hepatic uptake of LDL-C and lowering serum LDL-C levels. Remember that PCSK9 will cause degradation of the LDL receptor, whereas PCSK9 inhibitor will prevent the degradation of LDL receptor and cause the recycling of the LDL receptor for it to interact with more LDL cholesterol in the plasma to decrease its concentration or levels in the blood. In general, patients who are candidates for PCSK9 inhibition are patients with CVD, familial hypercholesterolemia, or diabetic patients with multiple risk factors and target organ damage who do not reach LDL target levels despite maximal tolerated dose of statin. It is also given to statin-intolerant patients who do not reach target levels despite ezetimibe and bile acid sequestrants and other lipid-lowering therapy. The next slide shows the LDL goals across cardiovascular risk categories. Low-risk patients should target an LDL level of 116 and below. Moderate-risk patients should target an LDL of 100. This includes patients who are diabetic and those who are considered high risk, like patients with familial hypercholesterolemia, those patients with markedly elevated single risk factors with LDL levels of above 190, those with moderate CKD or DM with the total target organ damage should be targeting a level of LDL of 70 milligrams per deciliter, whereas those patients who are very high risk, such as familial hypercholesterolemia patients with ASCVD, those with severe CKD, DM and target organ damage with moderate risk factors or early onset type 1 diabetes of long duration should target an LDL level of 55 milligrams per deciliter. The next slide shows us the extent of lipid lowering when comparing the different treatment regimen. Moderate intensity statins generally reduce LDL by 30%. High intensity statins reduce LDL by 50%, while high intensity statin plus ezetimibe causes a 65% LDL-C reduction. PCSK9 alone can decrease LDL by 60%, but combining it with high intensity statin, it will result to a reduction of 75%. Combining both PCSK9 and high-intensity statin with ezetimibe will further decrease the LDL level by 85%. So this is the slide that I showed you earlier, showing that among patients that are difficult to control LDL-C level despite maximal therapy, PCSK9 is at the bottom of the algorithm. So in conclusion, therapeutic inertia remains to be a problem in managing dyslipidemia. The intensity of LDL-C lowering therapy should be based on the risk and baseline LDL cholesterol level, which determines how much reduction of CV risk can be achieved. The greater the LDL reduction, the better the cardiovascular event reduction. Statins, ezetimibe, PCSK9, monoclonal antibodies are the lipid-lowering drugs proven to have benefit in cardiovascular event reduction and are safe in lowering down the LDL-C levels among these high-risk, very high-risk adult populations regardless of age. Thank you very much for your attention.